This is our technique for insertion of percutaneous hinge protective K-wire and screw in osteotomy around the knee. We also include a technical tip to remove percutaneously the hinge screw if needed. The patient is supine and a tourniquet may be inflated. A lateral hip positioner and a foot roll to allow the knee to remain 90 degrees flex are used. An arthroscopy is performed in the beginning of the surgery. The hinge protective wire is inserted after marking the osteotomy site with a 2 mm K-wire. This wire must intersect the osteotomy plane at the hinge location as shown in the circle, remaining close to the cortex, and its position is always confirmed by a fluoroscopy. For the medial opening wedge high tibia osteotomy, the hinge is planned at the upper third of the fibular head. The hinge K-wire is inserted at the midpoint between the jugular anteriorly and fibular head posteriorly. The K-wire should pierce the skin slightly higher than the articular line to facilitate this direction. The superior border of the tibial plateau is palpated with the K-wire, and the starting point is just at the tip of its lateral border and is directed slightly to medial along the tibial longitudinal axis. For the lateral closing wedge distal femoral osteotomy, the hinge is planned just above the level of the medial femoral condyle, adjacent to the downslope of the distal femur flare. The medial articular line is palpated, and the K-wire should pierce the skin slightly higher than the articular margin and just anterior to the medial epicondyle. The K-wire is advanced slightly to lateral along the femur axis until the metadiaphyseal junction. The ideal starting point, direction, and end point of the hinge protective K-wire and the hinge location for the remaining osteotomies are described in the text. The osteotomy is now performed. To insert the hinge screw after osteotomy is performed, the 2 mm K-wire protecting the hinge must be substituted by a small one of 1.6 mm. A small skin incision is made at the K-wire insertion, and a centralizer is slid until it reaches the bone. Then the centralizer is gently hammered by tapping on a second centralizer. This second centralizer is removed, and while the first centralizer is fixed on the bone, the K-wire is replaced usually just by hand. The orientation of the K-wire is verified by fluoroscopy, and then a 4.5 or a 6 mm headless cannulated screw is inserted, and final fluoroscopy images are obtained. For removing the hinge protecting screw, a small skin incision is made at the previous scar. Fluoroscopy images are used in both anterior, posterior, and lateral view to confirm the sagittal and coronal position of the head of the screw. A 1.6 mm K-wire is used and is advanced to pierce the screw. Then, as the head of the screw can be covered with bone, a 4.5 mm cannulated drill is used to remove the bone and gain access to the screw head. Finally, the cannulated screwdriver is slid along the wire until it reaches the screw head, allowing the screw to be easily removed. This technique is easy, fast, and reproducible. Thank you for watching.